All right, so Maryann and I are going to be chatting with you all for a little bit about social determinants of health and health disparities. We're just going to go ahead and dive in.
Wait, how do I? So I'm Maryann. I got to chat with you all in the last session, but I didn't formally introduce myself. So I work, as Deb mentioned, in the Community Health and Wellness Department. Well, Lianette and I both do, actually. And I am a preventive medicine public health trained physician. So I kind of bridge the clinic and community, and my role in the department is to kind of look at all of our programs with more clinical lens, and then I also see patients in our MAT program, MAT being the Medication Assisted Treatment Program, in which we help folks struggling with substance use disorder, specifically opioid use disorder, to recovery using a medication called Suboxone.
And my name is Lianette Pappaterra. My background is in public health, and I've been part of the community health and wellness team at Esperanza for 2 years. My title is Community Programs Manager, so I oversee all of our variety of programming and health education initiatives for different folks within the communities that we serve. And fun facts, in our spare time, Maryann and I like to explore Philly together. And we're always down to have some ice cream.
Mm-hmm. So as we mentioned, we're part of the Community Health and Wellness Department at Esperanza. This is our whole team. You all met Deb earlier today, so you've met half of our team. So we do community programming and health education for both patients and community members, and that's kind of a unique aspect of our department, is that we get to serve people who aren't necessarily patients at Esperanza. So we are, as Deb mentioned, focused on prevention, focused on looking beyond healthcare, and trying to keep people from getting sick. And so we work with families, children around nutrition, exercise. We have a health promoter program in which we try to equip local community leaders, and Lianette will talk a bit more about that. We work, as I mentioned, with families. So we have a couple of programs that are centered around families. So Family Fit, families get together and get opportunities to do physical activity and nutrition lessons together as a family, and behavioral health. And then we have Recipe for Health, in which they get to do some cooking and try new foods together. Our seniors program. We just recently started a parenting program, which Deb was discussing how we were trying to do in a more virtual platform. And we have a farmer's market, or produce market, called Esperanza Fresh. And also, one aspect of our department is the strategic partnerships across diverse sectors. So we interact with other churches, faith-based organizations, academic institutions, all center how do we care for our community as well.
So as Maryann mentioned, one of our programs is called the Community Health Promoter Program, and that's a real cornerstone of our department because that program actually preceded the creation of our department. I've had the pleasure of kind of overseeing that program for the last 2 years, and we invite community members who want to advocate for health in their communities, walk alongside folks making changes, positive changes in their life, make changes in their own life, and they go through a 9-week course. So a part of the lesson that we're actually teaching today, the piece that focuses more on social determinants of health, is actually pulled from the Community Health Promoter curriculum, which we thought was important because it's a way for you all to see, to get a little slice of what we're teaching folks in our communities. And it really centers on this image that you're seeing here, where we are looking at health from a very holistic lens, looking at physical health, of course, and delving into many physical health topics, but also looking at emotional and mental health, relational health, and spiritual health, and how all of these things intersect. So we spend the first couple of classes within the Health Promoter curriculum delving into what holistic health means in these 4 areas, and both within an individual and in terms of seeing these areas in others and how you can support. But now the question I want to start with is, what factors actually influence health, each of these areas of health, each of these pieces? So Maryann, if you could click to the next slide. I want to ask all of you, and this is very much meant to be participatory, so please unmute your microphones, shout things out, let's have a conversation. Can you all think of some factors that influence health on an individual level, within an individual person?
Family.
Yeah, family, absolutely.
Including genetics.
Genetics,
Where you live.
Yes.
What you eat.
Sure.
What you do for employment.
Okay.
Hygiene and discipline.
Sure, absolutely. Absolutely. Discipline, that's an interesting one. Can anyone expand more on that?
I think it can go many different ways, but one thing I was thinking of is like my spiritual health definitely depends on my own discipline at times. So, like be in the Word and have quiet time and stuff like that, and that affects like my emotional health as well.
Sure, absolutely, absolutely. Yeah, so these are all great ones, and some of the ones that you mentioned are even beyond the individual level. So we'll definitely get to those as well. But thinking about an individual person, some of the factors that influence their health include knowledge and skills. You need to know what is healthy, and you need to have the skills to be able to carry it out. Your attitudes and beliefs, your readiness and your willingness to change behaviors. If you're not ready to change behaviors, even if you know that something is not healthy or that something is healthy, you might not pick that thing up or put that thing down. Self-confidence, which in the public health world is often called self-efficacy. Emotions, if you are having a really bad day, that might influence what decisions you make, and if you're, that could impact your health. Access to health insurance, of course, your socioeconomic status, your immigration status. It's much harder to have access to healthcare resources when you are undocumented. Your education level, your race and ethnicity, genetics. So, and there are others, but this is one way that we can start thinking about health at the individual level. Within an individual person, all of these play a role in influencing and affecting one's health. So if we go to the next level, as we're going to be moving our way from the individual out, and so that's the interpersonal level. So someone had mentioned family in the last slide. That certainly plays a role in how you interact with the people around you that could influence your health. Can anyone think of any other factors at the interpersonal level that might influence health?
Your mental health.
Sure. Okay. So interpersonal is how you relate to other people around you.
Like what kind of support system you have around you.
Yes, support system is huge. Absolutely.
Maybe your status in the community, for example, if you're an immigrant to a new nation.
Sure. Absolutely. So Maryann, if you can click in. So family dynamics, how your family operates, those are the people that are closest to you and the ones who are going to most influence your health. Opinions of family and friends, and how much those opinions actually matter to you. If your mom's opinion really matters to you, you might take any advice that she gives you about your health more or less seriously, whether it's medically sound advice or not. Peer pressure, peer influence. Peer groups are a huge, huge impact, which goes back to your status in the community and who you're spending time with as well. Social support or lack of support, which we did mention, absolutely. And we're going to be moving even further out to thinking about our community and the built environment. So can anyone chime in with some factors that can influence health at the community or the built environment level? What is around you? What structures, systems are in place?
Access to healthy food.
Yes, absolutely.
The actual type of house or quality of house you live in or can afford to live in.
Mm-hmm. Yep.
The degree of community violence in your neighborhood.
Yes, safety and violence, right? Absolutely.
Environmental factors like pollution.
Mm-hmm. Mm-hmm. Anyone else? All right. So health facilities. Are there health clinics, pharmacies? Are there places where you can have an appointment or get your medications? Parks and green space. Are there places that you can exercise or safely play? Public transit. Can you get to where you need to go? Safety, as we mentioned, if you don't feel safe walking out of your block, then no matter how many times you're told that you need to walk more because of your diabetes or hypertension, you might not do it if you don't feel safe leaving your front door. Workplace conditions. Are you safe where you're working? What work are you involved in? What are the conditions there? Community resources, which can include a number of things: grocery stores, it can include nonprofits, it can include social services agencies, social institutions such as schools, businesses, and churches. Thinking about our school systems, is school a safe place to be? Is school a place where that nurtures learning or that nurtures other things? Churches play a large role in this community and built environment. What are churches doing in terms of outreach, in terms of providing services? Coalitions and community development associations and community cohesion. These really speak to the collective voice and power of a community. Are folks coming together and making sure that they're being heard, making sure that that there are positive changes happening, or is it a very disparate community where folks don't come together and lose out on that chance to make a difference and to change things that are not that are influencing health negatively in that community? So if we think about this overarching sort of umbrella of policy that plays a role and has an influence on all of these other levels, can anyone think of some policies that would influence health? What kinds of policy or laws would influence health? Anyone?
Like what kind of like chemicals or things that are allowed to be used within factories and even like cars and things like that?
Sure. Workplace safety, OSHA, and all of these organizations that are overseeing that. Absolutely.
Budgeting, where money is spent or placed in different parts of the city or the community.
Yes. Yeah. Budgeting and allocation of funds to different neighborhoods.
Even what we were just talking about earlier about COVID, like different health policies between different states with like COVID restrictions.
Yeah, so policy can be at the national, state, local level that can have an influence, absolutely. What about health insurance laws? Maryann, if you click in. Thank you. Medicare, Medicaid CHIP, the Affordable Care Act. Many states have expanded Medicaid and Medicare, other states do not. Who's eligible and what that actually covers, that has a huge impact on health. Governmental assistance programs such as SNAP or WIC or any number of other programs. Zoning laws, which would influence the distribution of resources. So what, thinking back to that built environment, what is and is not in your neighborhood? All right. So if we think about all of these levels and all of the factors and conditions that we've mentioned that have an influence and an impact on health, these together really help us understand what social determinants of health are. And according to the World Health Organization, they are the conditions in which people are born, grow, live, work, and age. And if we think about that, that is a huge implication. So health does not happen in an exam room. Health does not happen when you talk to your doctor. Health starts happening the moment that we are born and what the conditions that we're born into, both at all of the levels that we talked about. What does your community look like? What does your family dynamic look like? What are the policies in place that are going to be positive or negative impact on your health? So keeping that in mind, Maryann, if you can go click ahead for me. Thank you. These social determinants of health are shaped by the distribution of money, power, and resources at global, national, and local levels. So what we're talking about when we talk about social determinants are factors that are further upstream. So if you think about a river and the river current that's flowing downstream, there are all of these conditions in which we are born, in which we live, in which we grow, play, work, are impacting us. And the health effects of those impacts are seen much further down the road. So that's a really common term, the upstream and downstream factors that is used to think about causality and to ask that question of why. If we're seeing a health effect down the road, why is that health effect happening? And why is that happening? And why is that happening? And we're going to get into that much more with health disparities and health inequities. But these factors and this distribution of money, power, and resources causes health inequities, which is the unfair and avoidable differences. I'll say that again, unfair and avoidable differences in health status seen within and between countries and communities.
All right. So as Lianette mentioned, health inequities are these unfair and unavoidable differences, and they make up part of the broader framework of health disparities. So a disparity simply means a difference in the presence of disease, health outcomes, quality of healthcare, and access to healthcare services that exist across racial, ethnic, and socioeconomic groups. As we know, oftentimes this is due to these are unfair and avoidable differences. And so oftentimes, and in much of our conversation today, these will actually be health inequities. So we're going to continue on with the image and that Lianette started us with moving upstream. And we're going to keep asking this question, why? And we're going to look at Philadelphia specifically, and we're going to actually zoom in on the planning district that all of Esperanza's health centers are located. So if you look in the middle here of, I don't know, can you see my cursor or no? When I move it? Yep. Okay. Yep. So we're looking at the North Planning District here, which actually intersects across multiple different zip codes. And so Esperanza's health centers are all located in here. So Hunting Park is somewhere around here, I believe, and then K&A is, so this line actually, from my understanding, goes right along Kensington. So our K&A clinic is here and 5th Street is around here. So we're going to use Philadelphia as our case example to look at health disparities. And so as we go through each slide, we want to ask the question, why? So we're going to start all the way downstream. We're continuing that analogy. So all the way downstream, the effect, the health outcome that we're looking at in healthcare that we're trying to prevent is mortality. So let's look at mortality, our life expectancy in our planning district. And so these are from, also point out, these are from 2017. We didn't use the most recent data, mostly because how it was divided up in most recent reports was not by planning district, so it's a lot harder to see the data. So again, I'll point you to our North Planning District. So we see here that life expectancy is in the lowest quintile for females and for even lower for males, 67.5 years. While if you go just further to the northeast, you see 75.9 years in life expectancy. And this reminds me of this phrase that's often said when we're talking about social determinants of health, and that's that your zip code determines more of about your life and your life expectancy than your genetic code. You may have heard that before. So mortality, life expectancy is low. Why is that? So what is the most common cause of death? Top cause of death?
Overall in the United States, is that what you're asking? Heart disease, right?
Yeah, the cardiovascular disease. So we're going to keep asking why. So why are people dying at higher, have lower life expectancies? Well, we can start by asking, well, do they have a higher rate of cardiovascular disease? Because that is the most top cause of death. And we see that, yes, in fact, in our planning district, in the North Planning District, we have one of the highest rates of cardiovascular disease. So premature cardiovascular disease refers to cardiovascular disease before the age of 65. People are dying of heart disease before the age of 65. So we see 88.6 per 100,000 people. Well, why do they have higher rates of cardiovascular disease? What are some of the conditions that might lead someone to have a higher rate of cardiovascular disease, or would increase their likelihood of having cardiovascular disease? What are some health factors or health conditions? Thoughts?
Hypertension, diabetes.
Right, obesity. So we see, again, and you know, not our planning districts here in the north isn't always the highest, but you see that we have higher rates of adults with diabetes, higher rates of obesity, so 39.5, actually one of the highest in Philadelphia, and high blood pressure, also 41.75. So, all right. Why higher rates of diabetes, high blood pressure, and obesity? Why would this community have higher rates?
Access to food is different. The markets and things are spread out a little farther. So it's like, yeah, so food deserts is, I guess, the word I was looking for.
Food deserts, yep. Yeah, and you're getting at those social determinants of health that Lianette was talking about, things that are not in that individual sphere, but are impacting health on a more community level. Anything else?
It's cheaper to eat unhealthy.
Cheaper, yep.
So cheap.
Lack of safety for exercise outside.
Yep, for sure.
Access to healthcare might be lower in that community.
So we'll start with access to healthcare. You know, so we've already primed you guys to think, I think, public health and all the social determinants of health and everything that's happening outside, but oftentimes we think of of poor health and we think of healthcare. And healthcare is certainly a factor in someone's health, and we'll start there. We do see that indeed in our North Planning District that we have higher rates of adults without insurance, and that is certainly a factor that could impact people's health, lead them to have maybe undiagnosed diabetes, undiagnosed hypertension, limited access to the medications that they need because they can't afford it, and that would lead to increased risk of cardiovascular disease, increased risk of mortality. So certainly that plays a role. And then, yeah, we also see that, as someone mentioned, cost. So we have 19.8% of folks in this community, adults in this community, forego care due to cost. So certainly, economics, income, low income. But then this one's a bit interesting. So maybe we would think, well, there's less access to healthcare in these communities because there are less healthcare providers in this community. We actually see that that's not the case for. Actually, can you all see these numbers clearly? Because I don't have it as a full screen on my laptop. Is that impacting how you can see the maps and the numbers, or are you able to see it okay? Like, is it better when I do this? Sorry, I can't, can someone, I can't see you all.
I'm sorry, it looks good, looks fine, sorry.
Are they the same either way, or?
Same either way.
Same either way, okay. Then I will make it smaller so that I can see at least a few faces while I'm talking. So we see that in the North Planning District here, that actually we have a lower population per primary care provider. So we're actually doing better here in our North Planning District than, say, this community over here that has a much higher population per primary care physician. I'd like to say that Esperanza is helping with this number being lower than maybe one would expect. But we see even lower down in Center City. But that starts to help us understand that healthcare isn't the only factor, and you already know this, that healthcare isn't the only factor that contributes to somebody's health, but it is certainly an important part of it. All right, but you all already started mentioning all the other factors that happen in the community that might predispose someone to having diabetes, high blood pressure, obesity. And so we talked about access to healthcare, but also access to healthy foods and parks. So we see that in our North Planning area, District 34.4% reported low to no walkable access to healthy foods and high poverty. And then as far as access to nearby parks, 60.7%. No access to nearby parks or outdoor space. So oftentimes when someone has diabetes, high blood pressure, what do we tell them? We tell them, of course, take your meds, but then also make sure you exercise, make sure you eat better, eat healthier, eat more fruits and vegetables. And we see that this community has a lower likelihood to be able to carry out those health recommendations given by their healthcare provider. So we see as and this is, again, we're trying to go upstream. We're trying to see what we want to keep asking why. And actually, just like a personal story, that it was that question why that helped lead me into a career in preventive medicine, public health work. I kept wondering, well, why? Why are these communities suffering in these ways? Why is this? And at that point, I was thinking initially, early in my training, was thinking more on that individual level. Why is this particular person having struggled with their diabetes? And as we think of the spheres that Lianette was sharing with us, it starts on that individual level. Maybe some genetics, but then also what are their access issues, income level, all of those things, and then their interactions with others in their community, in their close circle, but then their community. That's when I started being more exposed to social determinants of health and understanding that there are conditions that people live in that that don't help them to make be able to carry out the health recommendations that we give them in clinic. But then there's the highest, even further upstream, as Lianette was talking about, is policy. Well, and even before we get to policy, there's the issues of race and racism. So we talked about that a little bit in our panel discussion with COVID. And we see, so we're thinking now systemic issues that are overlying all of the factors that we're talking about. And so we have some race data, and we see that higher rates of obesity among Black and Hispanic people, higher rates of hypertension among Black individuals, higher rates of diabetes among Black individuals, and we see uninsurance as well, much higher for Hispanics, and higher as well for Black individuals than white, and higher as well among Asian populations. And I mean, I found this one particularly just shocking to see the disparity here between white and Black asthma hospitalizations among children. And we could take some time to talk about, well, why is that? Certainly there could be systemic issues around racism, but also how things like access to housing. I think that was also discussed earlier. Unsafe housing. Is there mold and mildew or rodents in some of these older houses that could be impacting a child's asthma, or access to healthcare and medications, inhalers. And I know that you could explain so much more about what could be predisposing a child to have such a higher rate of asthma hospitalizations.
Yes. Well, at least in our neighborhood, substandard housing with lots of exposure to animal dander, including vermin dander. The vermin rate in our neighborhood is very high compared to the rest of the city. Smoking. And again, that has to do, we say smoke outside and the parents say they do, but again, if you don't feel safe going outside to smoke, you don't go outside to smoke. So yeah, lots of things like that. And also, I was gonna say too, poor exercise rate. Exercise only helps asthma. Generally, there are a few exceptions to that, but overall, exercise helps asthma. And so, lack of exercise. And the one thing about childhood obesity that I think is the most documented positive correlation is high screen time, low exercise. It's not diet. You think it would be diet, and added sugar. But the best documented one anyway, the best correlation in the studies is high screen time, low exercise. And so if they have no safe places to exercise, both their obesity and their asthma is going to be worse. Did I answer your question?
Mm-hmm. Yeah, thank you. And you brought up a good point about the smoking. So, and this is something important for you all as you're entering healthcare professions. When you give someone an instruction like quit smoking, it's bad for your kids' health. Some of you may know this term motivational interviewing, where we ask patients or community members, whatever context we're in, what we're trying to give them healthy behaviors, change their behaviors. We want to know, well, is this something you feel like you're able to do? Do you have the confidence that this is something you can do? Can you quit smoking? And when you have that kind of discussion with a patient, instead of just saying you must quit smoking, then you can start to understand the issues that are like those whys, those deeper issues that, sure, maybe they want to quit smoking, but or they want to quit. They want to smoke outside, but it's not safe to go outside. you know, that it's just I just wanted to take that example to remind us that it's always important to ask why and to go deeper with the patients or community members, whoever we're trying to encourage to make a healthy behavior change. We want to ask them those questions, see how feasible is the recommendation that we're giving them, because sometimes there are issues that are beyond what we see. Like, it makes sense, yeah, go smoke outside. Ideally, of course, quit smoking. But there could be factors that are outside of our view that impact someone's ability to carry out the recommendations that we're giving them. So that bit of an aside. But back to our maps here. And also feel free to interrupt at any point. I can't see everyone, so if you're raising your hand, I can't see it. But feel free to unmute and just jump in.
I was gonna, sorry, I tried raising my hand.
Sorry, probably.
Okay. One thing I learned in school this year, I was taking like a sustainability class, and they were talking about like toxic waste. And we were reading about how in Chester, Pennsylvania, they have like 4 mass incinerators, and that heavily affects like asthma and even like cancer at like a much younger age that people are starting to see. So that's like completely out of control, like, you know, children like growing up in those kinds of neighborhoods. That's part of like systemic racism too.
Mm-hmm. For sure. Thank you for sharing that, Pro. And I included this last graph here. So for most of, sorry for all these background noise, most of the health outcomes that we're looking at, we see that it's much higher among minority populations. But we see here that suicide deaths actually are higher among white individuals. And we could take time to talk about why and come up with some theories, but I included this just so that we want to be careful not to make assumptions, and also always be asking why. Well, why? I'm not sure why exactly, but I wanted to just include that as some data that is maybe different than maybe one would expect, and to encourage us always to be asking when we see some data or we see a population, we see a health outcome. Well, why is that? Does anyone have any thoughts they'd like to throw out? Well, we can move on. All right, so as Lianette mentioned, we're going upstream, we're starting from that individual circle all the way out to the policy level. And we're gonna, as Lianette mentioned, there's so many policies that impact health, but we're gonna focus on one particular example that has had deep impact, especially when we think about social or health inequities that have impacted people due to race. So want to ask how many people have heard about redlining? I won't be able to see everyone, but maybe raise your hands. Yeah, awesome. So many folks are familiar with redlining, which is great. I hadn't heard about it until, so I never heard about it in undergrad, never heard about it in medical school. Didn't hear it until I was getting my master's in public health during residency. So I'm glad that more and more people are learning about this. So does someone want to explain it? I'm talking so much.
I can barely hear.
You could barely hear, you said?
Yeah, I can't hear you speaking.
Oh. Sorry about that. I can move a little bit closer or speak a little louder. Is that
okay? I can hear you. If you were speaking, I can hear you now.
Okay. I'm not sure when I cut off, but I was asking about redlining, and if anyone who is familiar with it would like to share what they know about
Okay,
it.
okay, I'm sorry. I heard another voice in the background, and I wasn't sure if that was someone explaining it or if that was just background noise. I apologize.
No worries.
I could attempt to explain.
Sure.
Yeah, I mean, I looked at it in Chicago anyway, and I'm assuming it's similar.
Yep.
So as you have written there on the screen, it's like people will receive color ratings depending on how good or how much value neighborhoods have, essentially. And it can help determine if you're able to receive loans, but also for property values and that sort of thing. And it was extremely racialized, in that, like, even if you had one person of color in your neighborhood, I think you were considered a red neighborhood then. And even if there was a bordering neighborhood with someone of color in it, you were automatically marked down to like yellow, like the second tier one or whatever, from what I remember. So if people of color moved into these neighborhoods, their neighbors would be very upset about that as well, because their property value and stuff automatically went down. So there was a lot of like pressure on them for them to move out, or if they moved in, neighbors would leave that neighborhood automatically, causing certain areas of cities to become largely one race. Yeah. And for those areas to become like the poor areas of that city too. That's what I know about it.
Yeah, awesome. Did anyone want to add anything else?
I can attempt to add as well. From what I know, I don't know if it's like the federal or state government, but like they basically like kind of like when they're zoning the districts, like draw like the lines where like, and like I guess create like borders between where there are more like lower income or like Black communities. And that's why like the lines like tend to look really funky, because I guess like, yeah, they're basically like taking advantage of that, like where like more white people are with like higher incomes versus not. And I think that it also like affects like the schooling quality for like children in those areas, and also like loan approvals in like certain parts of neighborhoods, which affects like mortgage lenders like refusing certain people of like certain ranges.
Right.
But yeah, just like allocation of different like federal and state resources affects like the zone.
Yeah, and oh, sorry, was someone gonna say something? As you were saying, Pearl, as well, like the ability to get a loan and home ownership. Thank you, Pearl and Amy, for sharing. Yeah, so and wealth accumulation is very limited when you can't own a home. So yeah, exactly. So this was a practice in the 1930s. Neighborhoods were given a certain score to determine whether someone in that neighborhood could receive a loan. And the term redlining came about because the areas that were considered most hazardous, is the term that they used, were labeled in red. So this is an example of a redlining map in San Jose, but redlining happened all across the United States. And as mentioned, it was mostly based on race, included actually not just that Black population, so also sometimes Asian populations were as well included. And just to demonstrate how impactful policy changes can be, we see that, so this was a policy in the 1930s that was outlawed, I believe, in the 1960s. But until today, we see the impact of redlining. We continue to see that the communities that were redlined back then in the 1930s and marked as hazardous, so the studies found that 3 out of the 4 neighborhoods that were marked as hazardous in the 1930s, HOLC is the Homeowners Loan Corporation, are still struggling economically with lower incomes and higher proportions of minority residents. And this is just one example here in Philadelphia of the impact of redlining today. So you can see the the red, the areas that were redlined back in the 1930s. And then these circles are homicides. And it's a little bit harder, I think, to see on the map, but I think that this chart demonstrates it a bit clearer. So we see that the vast majority of homicides are happening in communities that were back in the 1930s labeled as hazardous or given even a C rating, which is definitely declining. So you see that the racism and the impact of these policies back in the 1930s continue to have an impact today. And so as you have a patient in your exam room, or you're interacting with a community member, and they're struggling with a certain health outcome, diabetes, whatever it may be, we want to be thinking about why is that? And as we ask these questions about why, we realize that the impact, the causes of their conditions today extend far wider than the factors that they can control, and the factors that occur inside the exam room. We see that there are impacts in the interpersonal level, impacts in their community, and that impacts due to policies, including policies that happened back in the 1930s. And so these are all things that we need to be keeping in mind as we care for our patients, care for community members. So as we think about wanting to partner with them, advocating for their health, we need to be thinking about all these levels. And these are all levels at which we see, or why we see health disparities and health inequities. And as we've alluded to, much of this is because of poverty. So the Department of Public Health said that poverty is the underlying determinant for many of the racial and ethnic disparities that persist in Philadelphia. And we see that more minority populations are living in poverty than white populations, with the percentage actually of Hispanic Philadelphians living in poverty being close to double, or perhaps even double that of white populations. And this is just to help us bring things together. This was actually from Scotland. So we want to undo the fundamental causes. So all of those, the inequities, the policy level issues. We want to prevent things happening on the community level. We want to mitigate things that are on the individual level to lead to equality in well-being, healthy life expectancy. And this is another image that kind of pulls everything together. So here you see the upstream, downstream, that river analogy that Lianette introduced us to. So as we go downstream, we're ending here on mortality, and that is the outcome that all the way downstream that we want to impact. But the further we go upstream, so here we have like individual factors, but then as we go upstream, we're going more into the community, and then more in the institution, and here at social inequities, including race and socioeconomic status. So as we want to combat health inequities, we need to be thinking about the social determinants of health that exist outside of health, the traditional health care. Though, of course, that is very, very important, and we will continue to work with our patients on providing them access to health care and the medications they need. But we also need to be thinking upstream. And oftentimes, that's where public health is focusing their work.
And just to add to that, if I may, Maryann.
Of course.
Looking back at that image, if you're noticing healthcare, it is so far downstream that it's right next to mortality. And so while healthcare is an incredibly important piece of the puzzle, absolutely, and the majority of you are wanting to go into healthcare roles, it's important as a healthcare provider to recognize all of the other pieces that come behind, that come further upstream when a person walks into your office for an appointment, or when a person walks into the hospital because something has gone horribly wrong, or they don't have access to a primary care physician, or any of those things. Just recognizing that healthcare professionals sit very far down, but especially in primary care settings, there's such a large opportunity to kind of open the floodgates a little bit in different ways. And that can be done through care management teams, through ancillary services with registered dietitians, for example, behavioral health consultants, things like that. Working as a team to really start addressing and unpacking all of those other pieces that come behind further upstream. So I just wanted to point that out too.
Thank you. And also pointing to the role of healthcare providers and professionals in advocacy. You know, we've seen many healthcare professionals speak up recently and talking about racism being a public health crisis. Really, you know, using our voices as healthcare providers who have seen the downstream effect, and trying to encourage policymakers and those who are impacting those upstream factors to realize that what we're seeing in the clinic, what we're seeing in that individual level, is being impacted by things that are happening in our systems, on a policy level, in our communities, in our schools, etc. Any questions before we move on to a quick activity?
One quick comment. It seems to me like, as Lianette was kind of alluding to, that once the patient is in the exam room with the physician, what generally we're trying to do is we're trying to prolong life expectancy in the face of an illness they already have, like high blood pressure, high blood sugar, stage 1 cancer, et cetera, et cetera, et cetera. We aren't, you know, the horse is out of the barn with regard to preventing that. To prevent all that, you've got to start either at a much, much younger age, go into pediatrics, or start talking about how we impact kind of some of these social determinants and community level things, to provide healthier foods, more places to exercise, less smoking, all that other kind of stuff.
Thank you. Yeah, absolutely. Or you could go into public health like Maryann and I. Yep. All right. So we're going to do a quick activity, but I want everyone to just stand up for a quick second. Stand up, stretch out a bit. Just take a 5-second stretch break. You've been sitting all morning listening to different people. All right. So I think it's helpful to put all of this into action and to talk through some of these pieces in a more concrete way. We've been doing a lot of sort of up here theoretical talking. So normally when I would do this activity with my health promoters, I would break everyone into groups and everyone would be working together and then we would share back. Unfortunately, this platform is a bit more challenging for that. So we're going to work as one large collective group, which means I want everyone to participate. So together, can someone just shout out a health issue that we want to focus on? And there's a couple of examples on the right side of the screen there. Or you can think of any other health topic that's of interest to you. And we're just going to move through the socio-ecological model and think about factors that influence that specific health issue at each level. So do any of these sound good, or what health issue would you all like to focus on? Please unmute your mic if you're trying to speak, because I can't see you.
Diabetes management.
Diabetes management. All right, thank you. Thanks for stepping up. So if we're looking at this socio-ecological model, which is the official name of this thing, starting at the individual level, What factors could influence someone's diabetes management? Go ahead and just shout things out. No need to raise your hand or anything. Just jump in.
Education level and like health literacy to understand what they can be doing in their like daily lifestyle to help manage their condition.
Mm-hmm.
The amount of like their ability to get transported to their doctor appointments, like to and from.
Okay, transportation and actually going to your doctor's appointments, having a doctor to go to appointments to.
The food that is available to them and what their diet.
Mm-hmm. Mm-hmm.
Maybe how like diligent they are about managing their diabetes in general.
Okay, yeah, absolutely. What about even the recognition that diabetes is something that they should be managing? If you are diagnosed with diabetes and it's something that your mom had and your dad had and your grandpa had, and they all say, oh, it's fine, I was told I had diabetes and I just eat whatever I want and it doesn't matter. There has to be a recognition and the belief that this is something worth making changes for, because diabetes management requires a lot of changes and monitoring. What else? Any other thoughts at the individual level? All right. What about at the interpersonal level, family dynamics, family relationships, who you interact with in your community more closely? How does that influence someone's diabetes management?
They may not be able to eat traditional meals with their families anymore in the same way, which can really impact maybe the way their family sees them or the way they feel community.
Right. Yeah, I was going to say, it may be hard for them to eat healthy if the rest of their family is not eating healthy and has no particular reason to eat healthy.
Or if they try to cook a healthy meal and all the kids and the husband are like, this is disgusting, we're not eating this, it's so gross.
The level of aggression that people have interpersonally among like family members and community that like creates stress.
Mm-hmm. Sure, absolutely. Mm-hmm. And as we mentioned before, what other family members think about diabetes and their own opinions on what you should do or not do. If everyone in your family thinks it's a huge deal and is expecting you to take it very seriously, it'll be harder to not do so. But if everyone in your family is like, oh, whatever, it'll be much easier to just sort of ignore it. What about in your community and your built environment? How do all the things around you when you step out your front door, how do they impact your diabetes management?
Work schedules, where you work. So if you're able to have the time to make doctor appointments and go, or even to like make good healthy food versus like picking up food on the way home, that's something.
Mm-hmm. Absolutely.
I think someone mentioned access to healthy food.
Yeah, for sure. Access to a safe space to exercise or walk. Access to a pharmacy to pick up your medication, your insulin. community resources. Anything else anyone wants to share on community and built environment? What about policy? How does policy affect your diabetes management?
Maybe the availability of insulin through policy.
Mm-hmm.
The cost of insulin.
Right, cost of medications. Mm-hmm. And what do most people need to cover cost of medications? Some type of health insurance. And that's certainly policy if you qualify for health insurance. All right. Anyone else want to add anything or have questions at this point? All right. Thank you all for jumping in with different ideas here. Maryann, if you could go to the next slide, please. Thank you. So normally when I do this activity with my health promoters, I really want them to think about the ways that they can be a positive influence on all of these factors, because this sounds pretty despairing when you live in that North Planning District that Maryann showed us. And you know that when we say that there's that zip code determines your life expectancy, and it's your zip code that has a lower life expectancy, that sits really in a hard place with people when it's your community and you love your community and you want to care for your community. So what I would have people do is circle factors that they could be a positive influence on as a community health promoter. But I changed the question for each of you, thinking about what can you influence as a healthcare professional? Where are the areas that you can be a positive impact? And so if we're thinking about that model with all the levels from individual, interpersonal, community, and policy, at what levels do you have the most influence as a healthcare provider?
You could definitely find ways to get into doing policy, getting into talking into government, speaking about communities, raising awareness, because you have that knowledge and that authority and the ability to do that, to where a patient or a patient population may not know, may not feel, or may not be heard. When you're a respected representative of that community, being able to say, hey, we need to do this to change. Whether it could be something as simple as saying, hey, we bring down this is a positive outcome or change in the community. This could be a positive outcome change for the city. So just being an advocate, I guess, is the simpler way to say it.
Right, absolutely. Being an advocate and using your expertise to be an advocate for your community. And I'm going to kind of wrap in the next question with this one. What are the ways that an understanding of social determinants of health and health inequities can inform your healthcare practice? Does anyone else want to comment on either of these kind of discussion questions?
I think when talking with patients and stuff, it's very important to understand the situation they come from. Because if we're going to like tell them the ways they need to address their diabetes, or like just tell them, you know, if they have lung issues and they have been smoking for many years, like you just need to stop smoking. That's going to be a lot less effective than if we are able to give resources and speak to them in a way that can actually make a difference, and like empower in certain ways and give dignity.
Mm-hmm. Yeah, thank you. Thank you for sharing.
I think a huge thing is just knowing what resources are in the community and having a lot of connections to different people. Like, for example, like knowing who's working at the community kitchen, or what churches you can go to that are giving out like lunches, or where testing sites are, or counseling, or anything.
Yeah, absolutely. Absolutely. And I think in that regard, it's so important to work as a team, because you as a healthcare provider don't necessarily have all the time in the world to be in the room with a patient. But when you're working as a team, that includes a social services team and a registered dietitian who knows the food-related resources in the community, and many others, it really allows that to be brought to the forefront in a very concrete way. So quickly, because I know that we are running short on time, but Maryann is a healthcare provider, really helped to kind of delineate some key concepts that we just want to leave you with. So really thinking about, when you're trying to think upstream, always listen and ask why, and not just accept things as they seem and make assumptions. Really get to know the why. And that will help you to address the root of the problem instead of just focusing on the end result or focusing on the health issue at hand. And allowing your patients, as Maryann mentioned, through techniques like motivational interviewing, as was mentioned before, really understanding your patients versus just giving instructions. I think that when patients feel that they have the power of choice and that they are making changes that they want to make because those changes matter to them and to something that's important in their life, the results tend to be better. And then engaging with your community strengths and assets to be an advocate for change, as was mentioned as well. So we just want to leave you with these couple of key ideas, and we thank you so much for participating and for jumping in and sharing your thoughts and ideas. And our emails are listed there if you want to learn more or hear more about the work that Maryann or myself are involved in, or just want to chat further. Please reach out. We would love to hear from you.
If you ever want to
And you can,
our department.
I'm sorry, Maryann, go ahead.
If you ever want to spend time with our department, want to see what we do, welcome. Be happy to have you.
Yeah.